For most in our audience, you've met Sue Kressly before. Sue has been a practicing pediatrician in Pennsylvania for many, many years, and a frequent presenter at our Business of Pediatrics programs over the years as well. This year, actually, we've been fortunate and blessed that we have had multiple pediatricians in our immediate community who've been president of the American Academy of Pediatrics, Lee Beers, Sandy Chung, and we consider Sue almost a local and a friend. So with that, we're going to try to transition to Sue. Sue, Shadon, how do we get this set up now?
Mark, can you hear me?
I can. Give us a second to get your voice a little louder. Can we hear? Sue, I think you are on.
Except for I can't see a slide advancer, so I'm going to have to say next slide if somebody would be so kind to do that for me.
That's right in my wheelhouse.
Hashtag better together. Terrific. Thanks so much for having me, and apologies for not being able to be there in person. I would if I could, but I have not yet figured out how to be two places at the same time. And really what I want to talk to you today is standing up for children in some challenging times, and where we stand as an academy and where we stand as pediatricians. Next slide. Learning objectives are on your screen. I have no disclosures. I want to go back to the learning objectives just for a second. Think of me as your middle school friend who sends you a chain letter, and you can't be the person who stops the chain, because some of the information I'm about to tell you is new to some people and well known to others, but we've been talking about this within our own community for so long that we need to amplify these messages to others. And so my challenge to you is to take something that you learned today and share it with 3 other people, and challenge them to share it with 3 other people. And whoever stops the chain, children and pediatricians will lose. So the challenge is to keep sharing the message, not only to your medical colleagues, your pediatric colleagues, but people in your community, so that everyone understands what's at stake when we don't invest for children. Next slide. Who are U.S. children? Well, as you can see in your clinics and we can see in our communities, they are highly diverse. They are a declining portion of the population, which we're going to spend some time talking about the implications of that. And there is large geographic variability with substantial population shifts that we'll look at. And there are interconnections in income, race and ethnicity, immigration, and geography that have implications for our child population of today and the future of every community. Next slide. So I want to spend a little time here. I happen to be born in 1960 on the left side of the screen, where children made up 36% of the population. And we are now living in a place where children make up 22% of the population. That is significant. Think about the declining child population. What does that mean? What does that mean for the economy of your community and your state? What does that mean for the workforce that we're looking for, both for our workforce and healthcare replacement, but the workforce at large? What does it mean when we're 22% of the population and shrinking? Regardless of what people forget, we all know that the 22% of kids is also 100% of the future, and it requires us to make everyone understand that it's important to invest in these kids as tomorrow's future. Next slide. So you should also take a look at what this means to the growing 65 and older, which will be me in another 6 weeks. But we are starting to really cross the line of a population. And if you look at traditionally what the economy and a lot of our infrastructure and our resources are spent on as a country, it is a lot of time and energy and money in Social Security and Medicare, which is a growing set of segment of the population. That is all supported by a healthy workforce. If we have a declining pediatric population, that means we have a declining population of workforce, future workforce, and near future workforce. And there are more and more older people that need to be supported. And so the children of the future are really bearing the burdens of many things, including supporting this aging demographic. And for people who really keep relegating children to the kids' table, speak to them about really what matters. All of your grandparents that you know, all of the people in your community, part of their success in aging gracefully and economically stable depends on the workforce. Next slide. So why does this matter? Really, because every economic sector and every community depends on this robust workforce. And we need young, healthy workers to care for the sick and the elderly, supply our groceries, work in industry, provide our transportation, work in whatever sector is important in your community. And seniors depend on those healthy workers for their benefits, including Medicare. This chart really compares the population pyramid of 1930 with that of 2023. And if you project where this might be going, we all know that that pyramid to the left is a very stable physical structure. If we invert it and we end up with a very top-heavy senior population with very small numbers in the bottom, that is not a stable physical structure, nor is it a stable community or healthy infrastructure for our economy. Next slide. So this should be no surprise to anyone here, but the children are not evenly distributed across this country. And I did not include a slide, but we need to also understand that pediatricians are not evenly distributed where the children are. Pediatricians tend to stay wherever they train for a lot of reasons, including that's where you start your life and have support systems. But if we're really going to give equitable care to every child in this country, we have to own, as part of our own profession, how do we serve these children and how do we perhaps redistribute our FAAPness to where the children are living across the country, because it's growing in the South, but not so much the Northeast. And we're going to see next slide where actually areas are growing and shrinking. Next slide, please. So in your area, I've pulled out the statistics for your area. You're actually growing a little bit, except for Maryland, but that is not true in the greater Northeast, where there are more and more pediatricians being trained and staying. And so we should really think about, what does this mean for your workforce? What does it mean for scaling up to be able to support both primary and specialty and pediatric surgical care for the kids in all of these areas across the country? And how do we make sure that every child, because they don't get to decide where they are born or where they live, has access to the same outcomes through pediatric expertise, no matter where they live? Next slide. Okay, let's shift a little bit to race and ethnicity. This really should surprise nobody in the audience. And it is one of the reasons that there is a lot of rhetoric about fear. The changing face of America is absolutely mirrored in the pediatric patients that we see in our clinics every day. And we are absolutely changing the face of what America looks like. And that is frightening to some people and exciting and hopeful to many of us. Next slide, please. Immigrants are an increasing share of US children. And we define this as children under 18 who are either foreign born or US born to immigrant parents. And this has been growing and is projected to continue to rise. More than 1 in 4 of America's children are immigrant children today. We are now at the same percentage level we were in the 1920s, when immigration was at its peak. And up nearly 20% since the 60s. And that, I think, is important, because many of our policymakers and decision makers are about my age. And they grew up in a place where immigration was really very, very low in the 60s, 70s, and 80s. As immigration has started to increase again, it is something that many of our policy and decision makers see as a threat. Many of us who work with these children and families understand that this is a huge opportunity and presents hope if we can change the narrative. Next slide, please. So this is very interesting. This comes from the Places study, and if you aren't familiar with the AAP's Places study, it is a survey that's longitudinal data of residents over time. And it's interesting to note that while 1 in 4 US children today are immigrant children, nearly half, or 4 out of 10, of our early to mid-career US pediatricians qualify as immigrant children. Pediatricians from immigrant backgrounds make up a large portion of the pediatric workforce and are important contributors to diversity in our workforce. And we know that outcomes for patients, children, and families are better when their team looks like them. Pediatricians are leading in the way in that many of us and our colleagues mirror the populations that we serve, which gives us hope. Next slide, please. I don't have to tell anyone the story of Medicare or Medicaid and what many call the unwinding of Medicaid after the pandemic, and I prefer to call it as the unraveling. An important investment we make in children is in their health care. And as you well know, Medicaid is the single biggest health insurance payer for the nation's children, with roughly half of all infants, children, and adolescents in this country covered by Medicaid or CHIP. But what you may not know is that Medicaid's key benefit has its roots in ensuring our nation's military readiness. And we're going to talk about that in a coming slide. But really, Medicaid is part of the backbone infrastructure of healthcare delivery for children. It is not really an entitlement program. It is health insurance that ensures half the nation's children. And we can't say that often enough and loud enough for the people in the cheap seats need to hear. Every person should really understand that when there's threats to Medicaid funding, there's threats to health insurance for every child. And also remember that Medicaid, this is not money that's getting sent in a check to Medicaid recipients. This is their health insurance that pays you and I to deliver health care. So it's not taking money out of the pockets of Medicaid recipients. It's taking away their health insurance, and it's taking money out of children's hospital delivery infrastructure so that we can provide the care that these patients need and deserve. Next slide. So let's talk about the percentage of children enrolled in the Medicaid and CHIP. And if you click through, this didn't render. So I have a different slide. It's okay. About where that is by state, and I can make sure that Mark and team get a copy of that slide so you can see it. Next slide, please. So what do we know about the current state of pediatric payment? First of all, that we're all fighting over the same dollar, and a dollar is not enough to take care of these children. We are really left with a small percentage of the healthcare expenditure and trying to do yeoman's work and advance care for every child with inadequate resources, no matter if you're a pediatric generalist, a pediatric subspecialist, or a pediatric surgeon. We are grossly undervalued and underpaid by the healthcare insurance infrastructure. Next slide, please. So this can be a little misleading, but I want to just frame this by saying this is not evenly true across the country. And we often are very myopic and only see what's in our backyard. This is Medicaid to Medicare fee index, but this is straight Medicaid, and almost no one takes straight Medicaid anymore. Almost everything is Medicaid managed care. And so this is highly variable across geographies, but it just goes to show you that even in your neck of the woods, when you compare DC, Maryland, and Virginia, you are not, the baseline Medicare to Medicaid index is not equivalent. And it's certainly different in some states as depicted by the colors across the map. So pediatricians who think, well, we're all getting inadequately paid by Medicaid, yes, that's true, but in some places it's significantly worse than others. Next slide, please. Okay, so why are we spending so much time talking about Medicaid? I hear this all the time from colleagues who say, well, I don't have a high percentage of Medicaid in my practice. How much does this really matter, Sue? Why aren't you going after the commercial insurers? And why are we talking so much about Medicaid? So let's start with the thing that I mentioned a few minutes ago. The entire pediatric healthcare delivery infrastructure is built on a Medicaid base. Let that sink in. And when I talk to people about this issue, my first question to them is, how many people in the audience have kids or grandkids? And generally, a lot of people raise their hands. And then I say, keep your hand up if your kid's covered by commercial insurance. So you think this talk about Medicaid doesn't matter to you and doesn't impact your kids and your grandkids? You're mistaken. Even your children who are commercially insured will be impacted significantly by cuts to Medicaid. Why? In part because children's hospitals depend on Medicaid a lot. Rural clinics depend on Medicaid a lot. If you pare back the payment of Medicaid, children's hospitals are going to have to decide, where do we cut our programs? Are we cutting our cancer program? Are we cutting our trauma program? Are we cutting our mental health program where we need to be increasing it instead of decreasing it? And in rural clinics, there are already many pediatric hospital beds and outpatient access that have closed because of underpayment and under-resourcing. That is even further threatened. So it doesn't matter when the infrastructure it forces places like rural communities and children's hospitals to cut back their services, that cuts back access for every single kid. And if your child needs access to a pediatric specialist, or you're in a rural community and they have an accident or need urgent pediatric expertise, doesn't matter what's on your insurance card. Those kids will not have the same access to pediatric expertise that they need and deserve. And so make sure that everyone in your community understands that this Medicaid cuts is not just about cutting Medicaid to those kids covered by Medicaid. It impacts all of us and our pediatric healthcare delivery system completely. And so I can't, again, say this enough. Please tell 3 people and make sure that they continue to spread the message. Next slide. Okay, so what do we know about financing and payment? And they're not the same thing. Talking about who should finance and how we finance healthcare delivery for children and how we get paid as providers of that healthcare are related, but not completely the same animal. If you haven't read the NASEM report that was chaired by Jim Perrin and Tina Chang, you should do so, or at least read the summary. But we know that all pediatric clinical team members are underpaid compared to adult medicine. In some places in the country, family doctors are getting paid more to take care of children than pediatricians. That's crazy. It's happened because there's a workforce shortage in primary care for adults. And so in some places, they've bumped payment for primary care to adult medicine specialists or adult medicine providers by 20 or 25%. And those people who take care of kids get a bump along the way for all the patients they take care of. They did not include pediatricians in primary care in that bump. But we know that 50% of kids are covered by Medicaid and CHIP. We know that the current RVU structure rewards procedures, not time and thinking. And people who thought that the new E&M changes were going to increase pay to us, it worked for adults. It did not work for pediatricians for a couple of reasons. Number one, almost every adult patient walks in the room and has at least 2 comorbid stable conditions, which means that our adult primary care colleagues start at a 99214 and work up. Our kids do not. When we bill by time, the first 20 minutes of the hour are billed at a higher rate than the last 20 minutes in an hour. And I don't know any other profession who discounts the more time they spend with someone, the cheaper it becomes. But the revaluing of the AMA's E&M services did not help pediatricians the way it was intended to do so. But here's an important thing to consider about health insurance. Health insurance is insurance. And when you look at the insurance industry as a whole, whether it is hurricane insurance, flood insurance, car insurance, or health insurance, insurance was never designed for preventive services. You don't use your car insurance to pay to rotate your tires, fix your brakes, and change your oil. Insurance was made to take catastrophic events and amortize risk over a large population. It is my feeling that that's in part why we in pediatrics feel like we're banging our heads against a wall. Insurance was never designed for prevention, for health promotion, for wellness. And it is one of the reasons that we are undervalued in a system that is an insurance-based system. So should we be thinking differently about who should be financing pediatric health promotion, wellness, early screening, detection and intervention? Should we be thinking about this differently and talking to different people, not just the health insurance sector? Next slide, please. You all know the current child health landscape. This came out of that NASEM report. We rank at the bottom despite spending a lot of money. But I have to remind people that a lot of other countries that we get compared to, they have a different social contract to elevate to a certain basic level of living. And many of their dollars in family leave, in paying for maternity care, in paying for doulas and support for young families, do not come out of their healthcare sector. They come out of different spend. And we throw all of that into healthcare in addressing social drivers and other needs for supporting young families, which is very different than any other, when a lot of the other developed countries who spend less than we do. We know that children living in poverty face poorer health and higher rates of health and mental health conditions. And we also know about all of the impacts of stress on children in this country. Next slide. So what complicates all of this is that we are having a smaller number of children and a birth rate. We're not alone in this. I was able to speak in Japan recently at a group, and there were 4 presidents of Pediatric Association. Everybody's got a declining population. South Korea actually has it the worst with 0.7 replacement rate. So they're literally 3 generations away from extinction. We have to figure out what this means and how we invest in children and support young families so young families feel supported economically in their community and the ability to have a child and raise them in a world that they see hopeful as a future. And this is one of the messages we need to drive to policymakers and decision makers. Next slide, please. Okay. If for those of you who didn't see this report, this was from it was published in 2023, but it was data from 2022, where they took young, healthy adults who applied to the military, or young adults who applied to the military, and found that actually 77% of them didn't qualify for military service for physical health reasons, mental health reasons, or both. Let that sink in. So when you talk about investing in the future, not only is it about the economy of all of our communities, it's about our military readiness. And for those of you who don't know the history of EPSDT, it was really born out of military similar problems a couple of decades ago. And so investing in health promotion of children is important for economy and our military strength. Next slide. Okay, this is a busy slide, and we all know this. The more you spend early in life, the better the payoff. And I'm going to ask somebody just click through these because while I talk through these slides, because there's a lot of animation on the slide. So if we know if we have more plasticity at a younger age, so the more it takes less investment to actually have higher payoff in health and through the life course. Next click. But if you end up not doing those things, you have detriment effects of challenges throughout the life course. Next click. Adults may be actually too late to really change the trajectory, and that's probably one of the reasons we're spending so much money on chronic disease care mitigation when we could be better spent upstream. Next click. And we also know that the interventions that we do when we, as adults, are have much less impact than they do as children. Next click. We also know that if we influence mother and infants early, we really have significant impact and we can keep the trajectory healthy. Next click. And child and adolescence, is an effective point to intervene, but earlier is better. Next click. And then we all know this human reproductive cycle. Next click. Because we understand, next click, that there's epigenetic influences. This is something that we know that is not known to the public, and we have to think about how we say this. If we are going to make America healthier and reduce chronic disease, we need to invest upstream in the pre-pregnancy and pregnancy and early childhood sphere, because those are the places that we can have the most impact so that we don't have epigenetic changes that then get passed on from generations and create more chronic disease and less healthy populations. So little bit of money upstream has a significant cost savings downstream. We know that as a pediatrician. The general world does not. Next slide. Okay, I want to shift gears a little bit about how the Academy is standing up for children. No matter what happens, we are keeping children as our North Star, but we are also talking about what it means to be a pediatrician and support us as science, fact-based professionals who matter to the future of the country. We are standing up and speaking out where it matters most. There's a lot going on, and so we are also deciding when it is our best interest to amplify someone else's lead and when to work behind the scenes. If pediatricians are not continue to be at the table, kids are on the menu. We have to be able to stay at the table so we can influence policy makers' decision making, and we can change the public discourse. Next slide. So where we've been spending a lot of time, Medicaid advocacy. And I'm telling you, pediatricians are showing up. They are showing up big. And thank you to all of you who have spoken out, written op-eds, written to your representatives, written to your congressmen. Keep going. The fight is not over. And more people have to understand what this means for your community. Next slide. There are state-by-state fact sheets and DC fact sheets for exactly what percentage of kids are in Medicaid in your neck of the woods. These are great leave-behinds. These are great infographics so that people in your community, and remember, there's constituents who vote for the policymakers. And so whether it's at your local coffee shop or your daycare drop-off or in your school environment or in your coffee shop and with your family members in your community, please make sure everyone really understands what's at risk for these Medicaid cuts, because again, not only do they impact these kids, they impact the pediatric healthcare delivery for every child. Next slide, please. Okay, we know research, and that is meaningful to many people in your audience, is a huge challenge. This is very important for the future of health of our children and also our young professional colleagues and their decisions about how to invest in research and advance child health. We are speaking up, but we are also amplifying voices of the research organizations that are receiving this money. The NIH indirect rate would cut about 4 billion reduction, would be amount to about a 4 billion reduction in funding to research institutions. We're making the case for the importance of federal support for pediatric research to Congress, communicating to the public that this has decades of downstream effects. When you interrupt research, it's not something you can just turn off and then turn on the spigot when things change in a different political environment. We will lose decades of forward progress just at a time where we're really seeing interventions that are life-changing for children across the life course. We know that we're on the tipping point of a lot of genetic interventions that will cure diseases that when we trained were never even thought to be curable. And so we really need to make sure that we continue to make people understand that this cuts to research really impacts cuts that impact the health of children for the foreseeable future. Next slide, please. Okay, so let's talk about vaccine delivery. This is one of the places where the AAP has chosen to own this because no one cares about the erosion of vaccine infrastructure as much as we do. But I will tell you that we have many allies in the field working to figure out how do we make sure that we do what we can to change what's happening in policy and decision making. You will see us being vocal. If you think we're not speaking out loudly enough about something, please reach out to me. We are thinking with the COVID decision, and I made these slides before that happened, about many of the implications about what it means. We're collecting all the things that pediatricians need to know, and we're working with colleagues behind the scenes and speaking up in public so that we know what this means. But this is one of those messages that I can't overemphasize. Please make people understand that by messing with the current vaccine delivery infrastructure, we run the risk that we lose all vaccines for children in this country. That's not the message that's getting out, but it's true. If you start not recommending vaccines for kids, what does that do to the payment mechanism? What does that do to VFC infrastructure, where we know at least half the kids in this country or more receive VFC vaccines for some or all of their vaccine series? It is, we are literally being threatened at every step of the vaccine payment, delivery, and investment in future vaccine infrastructure, including pharmaceuticals' willingness to do this. Some of you may not know that the vaccine delivery was threatened a couple of decades ago because of lawsuits, and that's where the Vaccine Injury Fund came from, so that there would be a mechanism to keep pharma investing in research and development to keep making and investing in research for new vaccines. This is all at risk again if we don't have people understanding how that works. And we have plenty of resources to help you make that case and are working on some sound bites that may resonate so that you can redistribute them to your audience as well. Next slide, please. We are speaking out on vaccines, and thank you for all of you who are also lending their voices. Op-eds were published in a bunch of places. What I've learned is if you start with the soundbite they want to take home, they will amplify what our messages are. So our voice matters. Your voice matters in your community. We know that people don't necessarily trust institutions at this point, but most people still trust their pediatrician in their community. So for those of you who are introverts, I encourage you to find a way to find your voice and amplify it in written word, in talking to people in your PTAs and your school communities find a way to make sure that people really understand how much it's at risk and what matters here. Next slide, please. And we will combat misinformation and disinformation and facts wherever we are invited. I will, some of you who I've called on, please, first of all, thank you. But when you are given an opportunity to speak up, please say yes. And if you need to step out of your exam room, we need to have our voices heard wherever we have an opportunity so that people really understand how much vaccines matter. And we will continue to speak up on Medicaid, vaccines, and the things that are core to pediatrics and the children and families we serve. Next slide, please. So what's next for us? Click, please. Please be brave. This is not easy, but our kids are counting us. And bold when you speak out for both the kids and families we serve and our profession. We have a lot at stake here. And Paul Wise at the advocacy conference earlier this year said something where he said, there's never been a better time to be a pediatrician. And I took pause for a second, but he explained, we have more opportunity to have significant impact for a lot of children, families, communities, and our profession if we speak up in a way that we can be understood and heard. So please take this message and amplify it. Next slide. Thanks for having me.
Thanks, Sue. Can you hear me?
I can.
We do have a minute or two if there are any, well, if we have any questions and need to come to the mics. Otherwise, Sue, I want to thank you for being a champion for pediatricians all these years and actually being a great voice and knowledge sharer for our community. We got your back. We're here to work with you and try to make things right for kids and pediatricians in our country. Looks like we have one quick question. Introduce yourself.
Hi there. My name is Ashley Moss. I'm a pediatrician here in Maryland. Thank you so much for this great talk. Really appreciate your time, Dr. Kressly. You mentioned earlier in your talk that perhaps we should be thinking of alternative ways of paying for preventive care since catastrophic care is easily justified by insurance. I'm just curious, what other alternatives have you considered?
Yeah, so there's economists, and I'm lucky enough to be, Andy Racine is the president-elect, and he's an economist by training, so he's smarter about this than I am. But we're starting to really just think about this differently. And this is not the right environment to be having this conversation, but I'm trying to plant seeds so some people smarter than me might be able to figure out do we take this from the military readiness budget? Do we go to the Chamber of Commerce? And is there something in an employer tax or something where you have to be able to pull funds from for prevention and health promotion? I don't have the answers, but it's a big question. And I think that it's part of the reason we're frustrated. Like, the health insurance industry was just never meant to do what we do in preventative care. I also will say that we might have an opportunity with the MAHA movement. If we're really going to talk about health promotion, prevention, and it's really talking about it, not just rhetoric. So anyone who's got great ideas to think about how we can economically think about where else some of these dollars come from, happy to entertain it and sort of go through the exercise. All ideas are welcome. And thanks for the question.
Thank you.
Maybe something we can bake into our Business of Pediatrics meeting coming up later this year. Actually, we're running short on time, and I'm trying to sort of keep things rolling. If that's okay, my apologies. Sue, I know you're in Georgia, but you made a big impact right here in our audience, right here in the DMV. We appreciate you, your leadership, and helping all of us who are taking care of kids stand up and do what's right. So thank you so much.
Thanks so much for having me, and please reach out to me. You're not bothering me. I'm happy to engage. Have a great conference.
Thanks.